Welcome everyone to the Lancet Laboratories Medcheck webinar with DNALYSIS Biotechnology. From myself, Bunene, on behalf of Lancet Laboratories and DNALYSIS Biotechnology, a very warm welcome to each and every one of you this evening. For those who have previously joined our webinars, we would like to thank you for your support and joining us yet again. And if this is your first webinar with us, then I would like to say welcome. Sit back, relax, and enjoy a very informative, well prepared evening of topics that will really interest and benefit you in your practice. I'm really excited about introducing the speakers to you this evening. It is a carefully hand selected panel comprising of only the best medical professional backgrounds, all with a long list of academic accolades and a wealth of knowledge that we will share with you this evening. Tonight's topics are all well centered around MedCheck. Our expert panel will each talk about different areas experts and approach thereof. They will share with us their expert opinions and views and help answer any questions you might have. So just before we get started and hand over to our first speaker, just a few logistics to navigate and find your way around our platform. To keep things as professional, concise, and focused as possible, we have muted all attendees. You will only be able to utilize the chat box when indicated to do so, but not be able to unmute or talk at all. There is a raise your hand button to enable us to get to all the questions asked in an orderly, organized manner. Now, without any further delays, I want to introduce to you our first speaker this evening. Dr. Danny Meyersfeld obtained his PhD in molecular biotechnology at Wits. He established DNALYSIS Biotechnology in 2008. This company has grown to become a leading player in the provision of nutrigenomics tests. Dr. Danny, I hand over to you, sir. You can please share your presentation.
Yeah, thanks. But at the end there, so I'm not sure if you finished your introduction. I'm going to go ahead and start. So first of all, putting this webinar together. It's great to be part of the webinar and to be joining Lancet as you guys start embracing this world of medicine. I've spoken to doctors over the years around pharmacogenetics, and often the response that I get from these doctors is that it's definitely something for the future. And what I'm hoping to impart on you this evening is that it's not something for the future. It's actually here now, and it's been around for a while. And these tests are now easily accessible, highly beneficial to you, to your patients, to your practice, and easily now available through Lancet Laboratories as well. So I mentioned personalized medicine. Personalized medicine, as most of you will know, is this practice of medicine that uses an individual's genetic profile to guide the prevention, diagnosis, and treatment of disease. And really what it is in a nutshell is the acknowledgement that every person, every patient that walks into your room is an individual and requires a unique intervention in order to ensure the best possible health outcome. So and the ability to now use genetic we firmly believe that the future of health lies in the person exercise, lifestyle, supplement, and prescription recommendations according to an individual's unique genetic code. And this allows healthcare to become predictive, preventive, and personalized. And it's written as though that is the future. But as I said at the beginning, it's a question that this has very much arrived and is accessible and available at our fingertips today. So what is pharmacogenetics? Pharmacogenetics is the convergence of pharmacology and genetics. It's the study of genetic variations which can affect an individual's response to drugs, both in terms of therapeutic effect as well as adverse effects. And pharmacogenetics aims to identify genetic biomarkers affecting drug response and use these to make better drug therapy decisions for everyone concerned. It was only when we started preparing to launch the Medcheck test approximately 4 years ago that I started looking at the statistics around adverse drug reactions and just how common these ADRs were and the extent of the burden that it places on an already overburdened healthcare system. So in the US, they're looking at approximately 100,000 deaths that occur annually due to adverse drug reactions. They estimate that 5% of hospital admissions are due directly to adverse drug reactions. And every year, an estimated 2 million people will be admitted to a hospital. Now, admittedly, we don't have precise statistics for adverse drug reactions in South Africa, but it is estimated that these numbers are likely to be similar, obviously prorated for population size. So this is the basic principle of pharmacogenomics, is that before a medication is prescribed, we do a genetic analysis to determine which patients have genetic variations that are going to alter drug metabolism or affect drug response. You're then able to preempt whether a person will respond to the normal dose as recommended the package insert of the drug, will potentially respond to a lower dose, might require a higher dose, or will be in some cases completely non-responsive. Prescribed. The idea with pharmacogenetics is to get the vast majority of the population into the immediate rapid response cohort in as short a period of time as possible. Now, when we look at drug metabolism, there are individual differences in the expression of proteins or enzymes due to genetic variations, which affect the absorption, the distribution, the metabolism, or the excretion of a drug. These effects could lead to changes in levels of the active or inactive drug metabolite, which can possibly be harmful or warrant the use of a different drug or dose of drug. And what might come as a surprise to some of you is that there's pharmacogenetic information on the labels of approximately 200 prescription medications approved by the US FDA. And on those package labels, it'll recommend the use of a pharmacogenetic test rather, in order to help guide the prescribing dosing decision-making process of the doctor. So to look at it in a rather simplified diagrammatic form, here we have an example of optimal drug metabolism, where normal levels of enzyme convert drugs into an active metabolites that are ultimately therapeutic and reach the therapeutic level within the blood at the expected drug dose. Here we have an example where due to a decrease due to a specific variation, there is now a decrease in enzyme activity, and this leads to insufficient active metabolites and therefore slow drug metabolism. And conversely, a different genetic variation may lead to rapid drug metabolism, where there's enhanced enzyme activity leading to greater concentration of the active metabolite. But that's a very simple illustration of how genetic variations can affect the metabolic activity of particular enzymes. So what are the clinical implications of these genetic variations? Well, if we look at the sciatica enzymes, there are more than 50 sub. It seems like I keep getting kicked out the meeting. I hope you guys are hearing me okay. So there are more than 50 sub-450 enzymes, which together metabolize approximately 80% of all drugs. And some of the key enzymes, which together account for close to 60% of those prescription medications, are CYP2D6 and CYP3A4 and 3A5. So this is an example of the genetic variation that can exist within the CYP2D6 gene. It's an incredibly heterogeneous genetic region, genetic sequence, which can have multiple different versions across different individuals. I'm showing just a handful of some of the most commonly identified combinations that we could find within an individual. There are over 100 known allelic variants, or 100 known variations of these different combinations of the gene. So this is just really a handful. But what we're showing here, if we look at example A, this is the CYP2D6 non-duplicated arrangement. In other words, the most common format of the gene, consisting of one copy each of CYP2D6, CYP2D7, and CYP2D8. Gene B is representing the typical CYP2D6 duplication arrangement. So here you see that CYP2D6 appears twice. The entire gene has been duplicated. In C, we have the entire gene being deleted. So there is no CYP2D6 gene at all, and we only have CYP2D7 and CYP2D8. D is an example of what we call gene fusions, where CYP2D6 is there by itself, but is also partially fused with CYP2D7, and the CYP2D7 allele by itself is missing. And in E, we have a fusion case with CYP2D7 and CYP2D6 having fused, but also in the presence of CYP2D7. And each one of these allelic variations would have different phenotypes or different manners in which a particular drug, for example, codeine in this case, would be metabolized by the patient. So CYP2D6 metabolic activity assessed in 290 subjects by administration of a probe substrate and measurement of urinary formation of the CYP2D6 generated metabolite. These pharmacokinetic and dynamic studies show a decrease in morphine levels and a decrease in analgesia in poor metabolizers receiving codeine. And by contrast, there's an increased conversion of codeine to morphine in your ultra-rapid metabolizers, which can result in extreme cases in toxic concentrations of morphine in the system. In terms of the percentage, that the vast majority of people, 7%, are what we call extensive metabolizers, which exhibit normal enzyme activity. But that still leaves 22% of the population, 2 in 5 patients, 2 in 10, 1 in who would be either an ultra-rapid metabolizer, an intermediate metabolizer where there's lower activity, So those will be completely unresponsive to administration of codeine. And I think this is something that we've all heard and seen. They could take as many pills as they want of a particular drug. It doesn't have any effect on their headache. It simply doesn't have sides. That is largely due to them most likely being poor metabolizers of that particular medication. So anecdotally, I think this is all something we've got experience with. And experience of non-responsiveness to different prescription medications. So the original case study of codeine and CYP2D6 was published in Lancet back in 2006, where a breastfeeding neonate was found dead on day 13. Post-mortem analysis had showed no anatomical anomalies. The blood concentration of morphine was 70 nanograms per ml. Whereas typically you'd expect that to be 0 to 2.2 nanograms per ml. The mother had been prescribed codeine at the recommended dose. Genotype analysis showed that the mom was an ultra-rapid metabolizer. She had the gene duplication that I showed you earlier and was classified as an ultra-rapid metabolizer of CYP2D6. This genotype then led to increased formation of morphine from codeine. And unfortunately, the baby died from morphine poisoning. The result was a black box warning in the FDA that appears in the drug label of codeine, warning that death related to ultra-rapid metabolism of codeine to morphine has been experienced in individuals who are known to be ultra-rapid metabolizers due to CYP2D6 polymorphism. And more recently, codeine has because of not knowing their genotype status. So this is just the black box warning that I spoke about. What are the Pharmacogenomics Implementation Consortium for codeine? So the coding therapy recommendations based on your CYP2D6 genotype. So who can benefit from a test of this nature? Anybody who is experiencing side effects to a specific medication, anybody who's not responding to specific medications or is requiring doses outside of the recommended range, and anybody who's planning to start on a new medication could potentially preemptively doing a pharmacogenetic test in order to ensure that the medication they're being prescribed is the most suitable medication that they should be given. So with that introduction, I'm going to show you a little bit about the Medcheck test that we offer and just explain to you what the report looks like. And hopefully some of these visuals will then assist you when Dr. Liebenberg goes through her case studies. It'll give you a bit of context to what she's referring to in the results that she speaks of. So I'm going to anticoagulants, antiplatelets, beta blockers, statins, proton pump inhibitors. Some of the psychiatric drugs include anti-addictives, antidepressants, antipsychotics, and benzodiazepines. And some of the pain medications include opioids and NSAIDs. In oncology, we look at anti-estrogens such as tamoxifen, antifolates such as methotrexate, protein kinase inhibitors like idofetinib and gefitinib. And we've specifically selected those scientifically valid and clinically actionable genes included in the test. There are hundreds, if not thousands, of candidate gene associations linked to pharmacogenetics. And the question is, where do you draw the line? What level of evidence do you require in order to include this in a commercial test that will be useful to the doctor in clinical practice? And the CPRC, as I'll show you later, ranks the gene levels by evidence. And we've limited the report only to those that exhibit levels 1A or 1B, which is the most rigorous evidence. It's the most scientifically valid evidence for the association between a particular genotype and the medication of interest. So when you send a report in, the patient's existing medications will appear first with any gene-drug interactions highlighted. This is simply to put that relevant information up front and center to make it easy for you to identify. So in this case, the patient has told us that they're taking simvastatin, methylphenidates, amitriptyline, and codeine. And you can immediately see on the front page, amitriptyline, codeine, and simvastatin have the big red cross, with the key on the right-hand side showing that information to be actionable, meaning that there is a specific clinical intervention available for either an alternative medication or an alternative dosage of that medication. So there's clearly defined clinical guidelines. The red cross means medication has potentially reduced efficacy, risk for a particular condition. A yellow triangle means that guidelines do exist for adjusting dosage, increased vigilance, or the patient has a moderate risk for the indicated condition. And green obviously meaning that the drug is safe and effective. And there was also, based on the level of evidence that we provide, we tell you whether that information can be labeled either actionable or informative. In the case of actionable, it means that recommendations are based on publications by international pharmacogenetic expert groups, consortia, or regulatory bodies, such as the CPRC, which is the Clinical Pharmacogenetics Implementation Consortium, the Dutch Pharmacogenetics Working Group, the FDA, or the European Medicines Agency. These recommendations are suitable for implementation in a clinical setting. Alternatively, they might be informative, in which case there's insufficient or contradictory findings documenting the impact of a given genetic polymorphism or drug reaction. Recommendations are therefore informative and subject to a bit more clinical discretion. In other words, you might choose to continue with a particular medication, but monitor the patient more closely for potential side effects. After highlighting the particular meds of interest upfront, if a patient is taking existing medications, value of pharmaceuticals apparent. Because we are highlighting over 200 different chronic medications in a once-off test that the patient has access to for the rest of their lives. So very clearly categorized in green, yellow, or red, standard precautions, use with caution, or consider alternatives. And at any point in the future, if there's a particular medication that is needing to be prescribed, either the patient or the referring doctor can refer back to this report to make sure that it is the most suitable medication for that particular person at that particular time. Finally, the last section of the report is the dosing guidelines. Every drug that is highlighted as either contraindicated with the red cross or the yellow triangle, telling you the red cross there, what you can do about it. Whether it's, as I said, whether it's an alternative medication, whether it's an alternative dosage, the dosing guidance is provided where available for every medication that's included in the report. And then just I mentioned some of the classes, but this is all of the medications covered in the Medcheck test. Over 200 drugs that we look at, mostly commonly prescribed medications. Look at some of the examples. For example, if there are any cardiologists sitting in, you might be interested to know that approximately 10% of your patients are completely non-responsive to Plavix. I've spoken with people who simply changed the statin, the class of statin that they were using, and it was in the terms of the muscle pain that they'd been experiencing from the one version of the drug. And so this tool is at fingertips, you know, and I think the important thing with pharmacogenetics is at no point are we trying to replace the role. There's still a clinical decision that needs to be made. There's still an important clinical diagnosis where we need to identify the most suitable class of drug or the best therapy for a particular condition. But once that's been narrowed down, identifying which medication is going to be most suitable is where we can really help. And I speak from personal experience with my wife. For 10 weeks on warfarin, they titrated her dose and her INR did not budge over 10 weeks. And eventually she switched to another drug and responded immediately. So it's one of those very, very obvious tests I feel that a lot of people should do. If it's a field of interest and you're looking to explore more, there's some excellent online resources that are available. PharmGKB is the pharmacogenetics knowledge base, and CPRC, as I mentioned, is the Clinical Pharmacogenetics Implementation Consortium. So PharmGKB collects, curates, and disseminates knowledge about the impact of human genetic variation on drug response. So the evidence available for particular recommendations. Everything is there from the basic primary pharmacogenetic literature all the way through to the eventual clinical implementation. They take you through this knowledge triangle, and you can follow the evidence and follow the research and do how the science has evolved over the last few years. And then the CPRC provides the guidelines that enable the translation of the genetic lab test into actionable prescribing decisions for specific drugs. The guidelines can be centered either around the genes or around the drugs. And as I mentioned, there's different levels of evidence, from level 4 being preliminary, level 3 being low evidence, and then moderate and high evidence. And the Medcheck test includes drugs primarily from level 1A and 1B. So these are really excellent resources if you wish to read a bit more about pharmacogenetics and some of the incredible research that has been done and is being done. These are really great resources. An overview, introduction of pharmacogenetics and the test that's available. I'm now going to hand over to Dr. Liebenberg, who's a psychiatrist in private practice who's been working with our test for many years now and has from what we'll find out, had quite a few success stories, and fortunately she's going to share some of those with us this evening. So I'll head back to, I think, back to Vaneni. Thanks very much.
Thank you so much, Dr. Meyersfeld. That was very informative, and I'm sure our attendees just learned so much from you today. We really do appreciate your time with us. I will introduce our next speaker for the night. Right, it is Dr. Lian Burke. She's a qualified Free State University. Pardon, she qualified at the University of Free State in 1977, one of the first women to do so. She subsequently held position in Windhoek, Tshwane, and Kimberley, working in pediatrics, anesthetics, and general practice. Her experience include 5 years at West End TB and Psychiatric Hospital in Kimberley as a superintendent and 2 years in Alcon School for physically disabled children. She is the author of several publications and has recently retired from the board of Psych MG as a director. Dr. Liebenberg is a co-founder and co-governor of Special Interest Group of Adult ADHD. Her other interests include anxiety disorders, specifically social anxiety and depression. Her topic today is Introduction to the Science. I will share her presentation with her. Doc, you can take over and unmute yourself in the meantime.
Good evening, everybody, and welcome. I'm sorry we can't meet face to face, which I'm sure we all prefer, but at least I'm sure you're in the comfort of your own homes. So I'm going from the scientific to the more clinical because I'm a clinician and I practice in private practice. So what we're trying to do is give the patient some practical help. Let's go to our first case study, please. So maybe you'll remember my titles if you don't remember anything else about the patient. So I've called Mrs. B the dancing queen, and she's been a practice of the patient of the practice where I worked since 1996. At that point, had quite small children, married quite young, had 3 episodes of postnatal depression. She's very perfectionistic, critical, has had catastrophic thinking all her life, but all of this worsened after each pregnancy. She's very impulsive and emotionally labile. I'm sure you can all identify with patients like that who come into your rooms and you feel like you've run a marathon by the time they leave. It's extremely emotionally exhausting. She has constant anxiety and then episodes of quite severe melancholic depression with suicidal ideation. And then she has highs where she's quite aggressive, she talks a lot, she laughs loudly, and she has some paranoid ideation. She's not paranoid, but she believes that everybody's against her and she's being victimized by everybody around her, including her children and her husband sometimes. We can go next slide, please. She's never worked outside of the home, but she has hobbies like ballroom dancing, which she does very seriously. And she paints pictures that she sells, and she's constantly at odds with everybody, her dancing instructor, her friends, her children, everybody. The husband, though, lucky for her, is quite a rich guy, so he indulges everything. Every whim. Dancing competitions in Blackpool in the UK. She has Botox and fillers when she wants them. She travels overseas a lot. And she has jewelry that I'm amazed at every time she comes to see me. But despite years of treatment, decades of treatment, lots of visits to the doctor, lots of medication, she has one of those scripts that passes on to the next page. She was really getting worse and not better. And of course, when she went into menopause, the whole thing seemed to get worse. Next slide, please. So the previous medication that she was on is just about the whole list of what we have available. All the SSRIs, valproate, lithium, anafranil, diazepam, tegretol, dormicum, triptanol, aripiprazole, lamictal, topamax, and I can go on. But she also has medical conditions. So she has high cholesterol, she's on thyroid replacement medication, and anti-inflammatory for generalized pain. Mostly she's been on high doses of fluoxetine, Valium, and lamictal, and topiramate. Mostly the last one because she wants to lose weight. Okay, we can go to the next. So I final diagnosis, sort of made a final diagnosis of bipolar mood disorder, but with a significant personality disorder, which is a mixed cluster B. She is quite narcissistic and quite histrionic as well. But there is a notable family history, which we would pay serious attention to. 2 of her children are also patients of the practice, and her mother was mentally ill, her father wasn't well. It's really not a good family history. So she's been to really lots of different doctors, and we've all found this case very difficult to manage. So 2020 and 2021, sort of with COVID and lockdown, she was very bad and constantly suicidal. She didn't want ECT. We tried ketamine infusions, of which the first one worked, and then she had a completely catastrophic reaction. So we didn't want to carry on with that. As in paranoid, hysterical, screaming, we couldn't carry on with that. Next one. So finally, we get to her DNA results. She has reduced dopamine receptor density and hypodopaminergic functioning. So this puts her at risk of antipsychotic-induced tardive dyskinesia, which is a horribly disfiguring movement disorder that especially women can get, and also weight gain. So when aripiprazole was tried, she had both. She had really bad tardive dyskinesia and also weight gain. Now, her folic acid gene activity is reduced. It's only 60% of normal. And I'll talk about that a little more later on, but this is potentially a risk factor for treatment-resistant mood disorders. And then all her medical stuff. She had had bad reactions to her statins, most anti-inflammatories, as well as codeine and morphine. They're all in the yellow zone, which says that they either won't help her at all or she will have quite bad side effects, which she did to all of the above. Next, please. So what we have in the green zone, green for go, is citalopram, desvenlafaxine, duloxetine, escitalopram, fluoxetine, mirtazapine, sertraline, and vortioxetine. In the yellow would be the fluvoxamine, and in the red, amitriptyline and nafranol, paroxetine, and venlafaxine. Because her CYP2D6, she's an intermediate or ultra-rapid metabolizer. The aripiprazole was in the green for her, but as we've read, because of the dopamine receptor density, she had really bad side effects. And lithium, which had also been given in the past, was actually in the yellow. Valium in the green. Next, please. So this is a very complicated case. I mean, it is draining for the doctors, but never mind the doctors. If you think of the quality of life that this patient has had over many decades, where she was judged a lot of the time as being quite histrionic and hysterical and difficult to please and complained a lot. And there are dimensions of personality and there are medical complications. I believe that we have ill-judged her. And I really include myself in that because she's one of those patients that if you see her on the list, you have a big sigh. But she's almost self-selected the medication that works well for her. So she's on fluoxetine, she's on her Valium when she needs it, she's on lamotrigine, and she's doing actually okay at the moment. But the folic acid supplementation has helped her a lot because we've been doing that for about a year now, since last year, 2021. She's actually not doing badly at the moment. I just think if we could have helped her earlier on, a lot of the complications in her life could have been prevented. Who knows? Anyway, next patient. So I have a really soft spot for this young guy. He saw me for the first time in 2018, age 19. He's a BCom student. So he was complaining of severe attention deficit disorder since childhood and had been on Ritalin from the child psychiatrist. There's a significant family history of ADHD, and his dad left the family when his mom was pregnant with him. So he really grew up without a father with his dad. Both the father as well as the uncle has bad ADHD. So he also presented with severe anxiety, could not sleep. He was shaking like a leaf the first time he came to see me. Couldn't speak to me at times. He got skin rashes from nervousness. If he had to speak up in class, if he even had to go to class, he got a rash. He was afraid of literally everything. He at times, long periods of months up to a time, he actually could not leave the house. He could not attend classes. He could not go out to buy food, actually. And his mood was very, very sad and down, although he wasn't suicidal. Physically, this child was very, very thin, with a pectus excavatum, which made him even more socially anxious. And he couldn't eat. He literally couldn't swallow food due to the anxiety. So quite a sick boy. Next one. So he was put on sertraline and Ritalin long-acting in 2018 with a very poor response. The anxiety didn't get much better, and the ADHD was really, really bad. He has a very high IQ, this child, but somehow he was battling to pass and just couldn't get through his studies. So we tried venlafaxine and we tried Oros methylphenidate at 72 milligrams. Once again, a poor response. He was even more anxious. He was getting panic attacks. So I tried him on mirtazapine so he could sleep and eat better. He was even able to attend classes and play soccer once a week. And he was also doing well academically. So good improvement, but still anxious and still having problems with attention and focus when he studies at home or in class. He was quite happy with lockdown, actually, because he could study in his own study and do what he wanted in his own time with nothing to distract him. Next. Right, so we checked his DNA, and unfortunately for him, both methylphenidate, so his Ritalin and his Concerta, and atomoxetine or Strattera were all in the yellow zone. As you know, used with caution, and what it meant is that it wasn't effective for him. But lisdexamfetamine or Vyvanse was actually in the green. We didn't have that until 2021 available in South Africa. So what I did was just increase his Concerta dosage to be able to help him. And it shows, his DNA shows a really poor response to the methylphenidate as well as the atomoxetine. And then his folic acid gene, once again, only 60% of normal activity. Now, this is associated with a poorer antidepressant response. It doesn't really matter which antidepressant you use. Folic acid is the building block of serotonin, dopamine, and noradrenaline in the brain. So these are the neurotransmitters we need to make the antidepressants and the other medications, especially for ADHD, actually be effective. So if you have a lack of folic acid in the brain, it's like telling a guy to build a wall, but you're not giving him the bricks and cement to do so. And what happens with the food we eat, so say we're eating green vegetables or whatever it is with folic acid in, it has to be methylated with this enzyme MTHFR to be able to enter the brain, and then it can form the neurotransmitter. So if you lack activity of that enzyme, your brain will lack folic acid and you're not going to get the response you want, whichever medication you use. Next, please. So for him in the green, we have fluoxetine, desvenlafaxine or Xera, and vortioxetine. And in the yellow was Wellbutrin and sertraline. And as we saw, sertraline for him was not effective. And he was so anxious that I think bupropion would have sent him through the roof. In the red would be citalopram, escitalopram, venlafaxine, paroxetine. And I think he was tried on some of those as a child to help with his anxiety, and they obviously didn't help. So can we move on, please? So what I've got him on is mirtazapine for the sleep and the appetite and the mood, fluoxetine 20, and then the Vyvanse or lisdexamfetamine 50 milligrams. So I saw him a few months ago. He's gained 10 kilograms. He has a lot of self-confidence. He's holding down 2 jobs, and he started his own business in the IT industry. He plays soccer twice a week, and he's attending his classes on campus, which is amazing for him. It's the first time in his life that he was able to do that. He was homeschooled. After getting 88% in the final year of his degree, he's now doing his honors degree. As in his own words, he's a different person. So for him, this has really been a success story, and it has changed his life. I think without the DNA testing, he would have had a hard journey ahead in his life. So a good story. Next one. Right, so now we're going to talk about the doctor's daughter. She first consulted me in July 2020 with her mother. It's quite a sad story. She's a 31-year-old, but she comes across as about 14. She's small, underweight, tearful, emotional reaction and responses would be that of a teenager. She has a lifelong, starting as a very young child actually, history of severe depression, constant suicidal ideation, and she's had numerous suicide attempts in her life. She's been admitted to various clinics, including Valkenberg in Cape Town, where she was admitted involuntarily. And the diagnosis finally made was borderline personality disorder. She also has an eating disorder. She's very thin, and she is on a vegan diet. Her father is a doctor, and he says it's all nonsense. So he's withdrawn all financial support. He says she doesn't want to get better. He's not helping her anymore. So despite struggling all her life, she only saw a psychiatrist for the first time in 2019. And this despite the fact that her brother is a schizophrenic. So once again, the family history is biologically significant, and one cannot ignore that when you are diagnosing a patient. And I think it's a risky diagnosis to make the borderline personality disorder if you're looking at the lifelong history and also the family history. So she has been on probably everything again, including valdoxin, Wellbutrin, Rivotril, Urbanol, citalopram, venlafaxine, and Olexa, none of which has helped her very much. Next one. So I restarted venlafaxine as that it worked best in the past and gave her quetiapine to sleep. Within the month, she had improved, but she was still very tired, and her diet was very poor, partly for financial reasons, but also because of her eating disorder. She also said to me she couldn't afford to buy avos, for instance, or very much vegetables of any kind. I think she kind of lived on 2-minute noodles, actually. But anyway, she also didn't want to gain weight. Can we try the next one, please? So I persuaded the mother to let us test her DNA because this was such a long, sad story. And here's a surprise. All antidepressants were in the green. So they should all have worked. It should have been fine if she'd been given, but her folic acid gene only had 30% activity because it had 2 copies of that specific variant. Next one. Okay, thank you. What I want to say with all of this is that the folic acid gene is very important, and you need to supplement with active folic acid, or they must eat lots of berries, which is the superfood for the brain because it contains methylated folic acid. And just to say that I am a clinician, so ultimately the diagnosis has to be a clinical one, and the treatment has to be based on clinical grounds. But this is a very useful tool, and it benefits our patients. I don't send everybody for these tests. It has to be somebody who's come a long way with difficult treatment, or who has side effects on medications, or somebody mostly resistant to treatment. And then we will send them for the tests, and almost always we get some positive results and we're able to help the patients better. So I thank you for your attention.
Understand better being a doctor from my side. Our key does have all right, it looks like we do not have any questions. In that case, that means you all answered everybody's questions really well. It was very informative. Thank you again one more time to you, Dr. Meyersfeld and Dr. Liebenberg, for making time today and sharing with us such beautiful information about Medcheck. Now, to all attendees, just a short announcement before we end tonight's webinar. Please ensure you complete the attendance register, which will be available on the chat box in a few minutes. This attendance register will be shared with HPSA for all CBD points to be allocated electronically. Very importantly, please note that this webinar will be recorded and available at the Lancet Laboratories website. We have ensured that those who could not attend due to tonight's either religious, family, personal, or business commitment still have the benefit of enjoying tonight's discussion. I would also like to humbly thank our presenters for their outstanding, very informative presentations and for availing themselves tonight for this discussion. Right from our company, Lancet Laboratories and DNALYSIS Biotechnology, I would like to thank you for your continued support and thank you for attending these webinar events. Should you have any suggestion whatsoever about topics of interest, please feel free to contact the Lancet Laboratories events team. Details are on your screen. We do look forward to hearing from you. And if you still do have any questions, feel free as well to answer them. We will share them with our presenters and they will gladly assist you. Once again, thank you all so much. Have a beautiful night. Goodbye all.
Thanks, Vinnie. Thank you. Bye, everyone.
Good night. Thank you. Bye-bye.